You're 45 years old, feeling perfectly fine, when your doctor tells you your blood pressure is slightly elevated. Within months, you're on one medication, then two, then three. Fast forward 15 years, and you're dizzy, weak, and barely recognizing yourself. Your blood pressure readings are so low they'd make a healthy teenager concerned, yet somehow you're still taking multiple medications daily. Sound familiar? You're not alone, and what I'm about to share with you might just save your life or the life of someone you love. What if I told you that millions of people worldwide are walking around with dangerously low blood pressure because they're taking medications they no longer need? What if I told you that this isn't just about feeling a bit dizzy or tired, but about a systematic problem that's putting countless lives at risk every single day? The blood pressure treatment crisis isn't just a medical issue, it's a human tragedy, playing out in homes, clinics, and hospitals across the globe. Every morning, millions of people wake up and dutifully take their blood pressure medications, just as they've been doing for years, maybe even decades. They trust their doctors, they follow their prescriptions, and they believe they're doing the right thing for their health. But here's the shocking truth. A significant portion of these people are being overtreated to the point where their medication is actually harming them rather than helping them. The story I'm about to tell you represents thousands of similar cases happening every single day. It's a story about Sarah, a 68-year-old grandmother who had been taking blood pressure medications for over 20 years. She started with one pill in her late 40s when her doctor noticed her readings were consistently above the recommended guidelines. Over the years, as her age increased and her readings fluctuated, more medications were added to her regimen. By the time she reached her late 60s, Sarah was taking 4 different blood pressure medications every single day. Sarah's daily routine had become a careful dance around her medications. She'd wake up feeling dizzy and would have to sit on the edge of her bed for several minutes before standing. Walking to the bathroom required holding onto furniture for support. Her energy levels had plummeted over the years, and she'd attributed this to normal aging. Her family noticed she wasn't quite herself anymore, but they'd assumed this was just part of getting older. The turning point came when Sarah needed a routine surgical procedure. She was admitted to the hospital for what should have been a straightforward operation. Her blood pressure upon admission was 95/60, already concerning low, but the hospital protocol dictated that she continue taking all her prescribed medications unless specifically contraindicated. Every morning at 8 o'clock, like clockwork, the nurse would arrive with Sarah's medication cup containing her 4 blood pressure pills. Sarah's daughter, who had been reading about medication management in elderly patients, noticed something alarming. Her mother's blood pressure readings displayed on the monitor were consistently in the low 90s, sometimes dropping into the 80s. Yet every morning, those 4 pills were still being administered. When she questioned the nurse about whether it was safe to give blood pressure medications to someone with such low readings, she was initially met with resistance. The nurse explained that doctors' orders were to continue the medications as prescribed, but Sarah's daughter persisted. She had learned that blood pressure needs change as we age, and that what's appropriate for a 50-year-old might be dangerous for a 70-year-old. She requested to speak with the attending physician and asked a simple question. Given that my mother's blood pressure is already low, is it safe to continue giving her medications that will lower it even further? This question sparked a review of Sarah's case that should have happened automatically but didn't. The medical team realized that Sarah's blood pressure medications hadn't been properly adjusted for her age, her current health status, or her actual blood pressure readings. Over the years, medications had been added but rarely subtracted. The assumption was that if she needed blood pressure medication at 45, she would need even more at 65. The reality is that Sarah's case is far from unique. Across hospitals and clinics worldwide, there are countless patients whose blood pressure medications are being continued out of habit rather than medical necessity. The protocols that govern medication administration often fail to account for the dynamic nature of blood pressure and the changing needs of aging patients. What makes this situation even more concerning is that the consequences of overtreatment aren't just about feeling a bit dizzy or tired. When blood pressure drops to low, especially in elderly patients, it can lead to falls, fractures, reduced cognitive function, and even life-threatening complications. The very medications prescribed to protect cardiovascular health can end up causing more harm than good when not properly managed. The medical community has become so focused on the dangers of high blood pressure that they've lost sight of the Equally serious dangers of blood pressure that's too low. The guidelines that doctors follow are often based on population studies and don't always translate well to individual patients, especially those who are elderly, frail, or dealing with multiple health conditions. This isn't about doctors being incompetent or malicious. Most healthcare providers genuinely want to help their patients. The problem lies in a system that prioritizes protocol over personalized care, that adds medications more readily than it removes them, and that fails to regularly reassess whether treatments that were once appropriate are still beneficial. The solution isn't to abandon blood pressure treatment altogether. High blood pressure is indeed a serious condition that can lead to strokes, heart attacks, and kidney disease. The solution is to approach blood pressure management with the same careful consideration we'd give to any other medical intervention. We need to ask not just does this patient have high blood pressure, but does this patient still need these specific medications at these specific doses? The blood pressure overtreatment crisis didn't emerge overnight. It's the result of decades of medical practice evolution, guideline development, and a healthcare system that's become increasingly protocol-driven rather than patient-centered. To understand how we got here, we need to examine the various factors that have contributed to this widespread problem. Medical education plays a significant role in this crisis. Young doctors are taught to follow guidelines and protocols, which is generally good practice. However, they're often not adequately trained to think critically about when those guidelines might not apply to individual patients. The emphasis is on starting treatments rather than stopping them, on adding medications rather than subtracting them. This creates a medical culture where more intervention is often seen as better care, even when the opposite might be true. The pharmaceutical industry has also contributed to this problem, though not necessarily through malicious intent. The development of newer, more effective blood pressure medications has been a genuine medical advancement. However, the marketing and promotion of these medications has created an environment where prescribing them is seen as progressive, modern medicine. There's less emphasis on the equally important skill of knowing when to reduce or discontinue medications. Medical liability concerns have created another layer of complexity. Doctors are more likely to be sued for undertreating a condition than for overtreating it. If a patient has a stroke and their blood pressure wasn't aggressively managed, that's seen as potential malpractice. If a patient falls and breaks a hip because their blood pressure medications made them dizzy, that's more likely to be viewed as an unfortunate side effect rather than medical negligence. This legal reality influences prescribing patterns in ways that don't always serve patients' best interests. The structure of modern medical practice also contributes to this problem. Doctors often have limited time with each patient, making it easier to continue existing prescriptions rather than conduct thorough medication reviews. Adding a new medication takes just a few minutes, but properly evaluating whether existing medications are still necessary requires time that many healthcare systems don't provide. Electronic health records, while valuable tools, have also created some unintended consequences. These systems often have built-in alerts for high blood pressure readings, prompting doctors to increase medications. However, they're less likely to have alerts for blood pressure that's too low, especially in elderly patients. The technology that was designed to improve care has inadvertently created a bias toward overtreatment. The problem becomes even more complex when we consider how blood pressure changes with age. As people get older, their blood vessels naturally become less elastic, which can lead to higher blood pressure readings. However, other age-related changes, such as reduced kidney function and changes in how the body processes medications, can actually make blood pressure medications more potent. An elderly person might need lower doses of the same medications they took when they were younger, but this adjustment often doesn't happen. Hospital protocols represent another significant aspect of this problem. Hospitals are designed to manage acute medical conditions, and their protocols reflect this focus. When a patient is admitted to the hospital, their home medications are typically continued unless there's a specific reason to stop them. This makes sense for many medications, but blood pressure medications require more nuanced management, especially when patients are ill. When people are sick, their blood pressure often drops naturally. Their bodies are fighting infection, dealing with pain, or recovering from surgery, all of which can affect blood pressure. Continuing the same blood pressure medications that were appropriate when the person was healthy can lead to dangerously low blood pressure when they're unwell. Yet hospital protocols often don't account for this physiological reality. The timing of medication administration in hospitals also creates problems. Blood pressure medications are typically given at the same time every day, usually in the morning, regardless of what the patient's actual blood pressure is at that moment. A patient might have a blood pressure reading of 100/65, which is already concerning low, but still receive multiple blood pressure medications because the protocol says to give them unless the blood pressure is below a certain threshold, often set at 90 or 95 systolic. This threshold-based approach to medication administration represents a fundamental misunderstanding of how blood pressure medications work. These medications don't just affect blood pressure at the moment they're given, they continue to work for hours afterward. Giving blood pressure medications to someone whose blood pressure is already borderline low is like adding fuel to a fire that's already burning too hot. The consequences of this systematic overtreatment extend far beyond individual patients. Emergency rooms see increased numbers of elderly patients coming in with falls, many of which are related to dizziness and weakness caused by blood pressure that's too low. These falls can result in serious injuries, including hip fractures and head trauma, leading to additional healthcare costs and reduced quality of life for patients. The psychological impact of overtreatment is also significant. Patients who are overtreated often feel weak, dizzy, and generally unwell, but they and their families may not realize that their medications are the cause. They may attribute these symptoms to aging or underlying health conditions, accepting a reduced quality of life that's actually preventable. Healthcare systems are beginning to recognize this problem, but change is slow. Some hospitals have implemented more sophisticated protocols for blood pressure medication management, but these are not yet universal. Some medical schools are beginning to teach more about the prescribing, the process of carefully reducing or eliminating medications that are no longer beneficial, but this is still not a standard part of medical education. The economic costs of blood pressure overtreatment are substantial, and necessary medications cost healthcare systems billions of dollars annually. The complications from overtreatment, including falls, fractures, and emergency room visits, add additional costs. Perhaps most importantly, the reduced quality of life experienced by overtreated patients represents an immeasurable cost to individuals and families. Hospitals represent the most dangerous environment for blood pressure medication overtreatment, and understanding why this happens could literally save your life or the life of someone you love. The hospital setting creates a perfect storm of factors that lead to medication mismanagement, and the consequences can be immediate and severe. When patients enter the hospital, they're typically dealing with some form of illness or medical condition that has disrupted their normal physiological state. This disruption often includes changes in blood pressure. Infections can cause blood pressure to drop. Dehydration, which is common in hospitalized patients, can also lower blood pressure. Pain medications, anesthesia, and many other treatments used in hospitals can affect blood pressure. Yet despite these predictable changes, blood pressure medications are often continued at the same doses that were prescribed when the patient was healthy and at home. The story of Robert illustrates this problem perfectly. Robert was a 72-year-old man who had been taking 3 blood pressure medications for over a decade. At home, these medications kept his blood pressure in a reasonable range, though even there he occasionally felt dizzy when standing up quickly. When Robert developed pneumonia and was hospitalized, his blood pressure naturally dropped due to the infection and dehydration. His admission blood pressure was 98/58, already lower than ideal for a man his age. Despite this low reading, Robert's home medications were continued according to standard hospital protocol. Every morning at 8 a.m., he received his 3 blood pressure pills with his other medications. Within an hour of taking these medications, Robert's blood pressure would drop into the 80s systolic. He felt weak, dizzy, and confused, but these symptoms were attributed to his pneumonia rather than his medications. On the 4th day of his hospitalization, Robert attempted to get up to use the bathroom. The combination of his low blood pressure and the lingering effects of his morning medications caused him to feel extremely dizzy. He fell, hitting his head on the bedside table and fracturing his hip, what should have been a straightforward Treatment for pneumonia became a complex medical case involving emergency surgery and months of rehabilitation. This scenario plays out in hospitals around the world every single day. Patients who are already compromised by illness receive medications that further compromise their stability. The falls that result from medication-induced low blood pressure are so common that many hospitals have implemented fall prevention protocols, but these protocols often focus on physical interventions like bed alarms rather than addressing the root cause: inappropriate medication management. The timing of medication administration in hospitals creates additional problems. Most hospitals have standardized medication times, typically 8 a.m., 12 p.m., and 6 p.m. for medications given 3 times daily. This schedule is designed for operational efficiency rather than patient safety. Blood pressure medications given at 8 a.m. will have their peak effect between 9 a.m. and 11 a.m., which is exactly when many patients are most active, trying to get up, walk, or participate in physical therapy. Hospital nurses, who are on the front lines of medication administration, often recognize these patterns. Experienced nurses know that rapid response calls, where medical teams rush to help patients who are becoming critically ill, most commonly occur within an hour of medication administration. They see patients who were stable before medications, becoming dizzy, confused, or even unconscious after receiving their pills. However, nurses often don't have the authority to hold medications without specific doctor's orders, even when their clinical judgment suggests it would be appropriate. The electronic medical record systems used in most hospitals contribute to this problem. These systems are designed to ensure that patients receive their prescribed medications on time, which is generally a good thing. However, they often don't have sophisticated decision support tools that would alert healthcare providers when a patient's current condition might make their prescribed medications inappropriate. For example, a patient might have a blood pressure reading of 95/55 documented in their chart, but if their prescribed medications don't have a specific hold parameter that covers this reading, the system will still prompt the nurse to give the medications. Many doctors write hold parameters like hold if systolic blood pressure less than 90, but this threshold is often too low, especially for elderly patients or those who are already compromised by illness. The culture of medicine also plays a role in this problem. There's often more concern about the theoretical risks of not treating high blood pressure than about the immediate risks of treating blood pressure that's already too low. Medical students and residents are taught to be aggressive about blood pressure management, but they're given less training about when to ease up on treatment. The complexity of modern blood pressure management also contributes to hospital-based overtreatment. Many patients are on multiple blood pressure medications with different mechanisms of action and different durations of effect. Some medications work for 24 hours, others for 12 hours, and some have effects that can last for days. Managing this complexity requires careful attention to each patient's individual circumstances, but hospital protocols often treat all blood pressure medications as if they're the same. The shift change culture in hospitals creates additional challenges. Nurses typically work 12-hour shifts, and doctors may rotate every few days. This constant turnover means that the healthcare providers caring for a patient may not be familiar with their baseline condition or how they've been responding to medications. A patient who was stable yesterday might be having problems today, but the new nurse or doctor might not recognize the pattern. Family members and patients themselves often don't realize they have the right to question medication administration in the hospital. They assume that the medical team knows best and that all prescribed medications are necessary. However, patients and families are often in the best position to notice when something isn't right. They know how the patient normally feels and acts, and they can often detect changes that healthcare providers might miss. The legal and regulatory environment also influences hospital medication practices. Hospitals are regularly inspected and audited, and one of the things inspectors look for is whether patients are receiving their prescribed medications as ordered. There's less scrutiny of whether those medications are still appropriate for the patient's current condition. The solution to the blood pressure overtreatment crisis isn't to abandon blood pressure management altogether, but rather to become an active, informed participant in your own healthcare. This means understanding how blood pressure medications work, knowing what to look for, and being prepared to advocate for yourself and your loved ones when necessary. The first step in protecting yourself is understanding that blood pressure needs change over time. The medication regimen that was appropriate when you were 50 might not be appropriate when you're 70. As we age, our bodies process medications differently, our blood vessels change, and our overall health status evolves. These changes should be reflected in our medication management, but they often aren't unless we specifically ask for a review. Regular blood pressure monitoring at home is crucial for anyone taking blood pressure medications. This isn't just about checking whether your medications are working. It's about ensuring they're not working too well. If you're regularly seeing blood pressure readings with a systolic pressure in the 90s or low 100s, especially if you're experiencing symptoms like dizziness, fatigue, or weakness, it's time to have a conversation with your doctor about whether your medication regimen needs adjustment. When monitoring your blood pressure at home, timing matters. Check your blood pressure before taking your morning medications to get a baseline reading. Then check it again 1 to 2 hours after taking your medications to see how much they're affecting you. If your blood pressure drops significantly after taking your medications, or if you feel dizzy or weak during this time, document these findings and discuss them with your healthcare provider. Preparing for medical appointments is essential for effective blood pressure management. Keep a log of your blood pressure readings, noting the time of day, whether you'd taken your medications, and how you were feeling. Also document any symptoms you're experiencing, such as dizziness, fatigue, or difficulty concentrating. This information will help your doctor make informed decisions about your medication regimen. Don't be afraid to ask questions during medical appointments. Some important questions to consider include, are all of my blood pressure medications still necessary? Could any of my symptoms be related to my blood pressure being too low? How do you determine the right blood pressure target for someone my age? When was the last time we reviewed whether I still need all these medications? If you're scheduled for a hospital stay, preparation becomes even more critical. Before you're admitted, ask your doctor whether your blood pressure medication should be continued at the same doses during your hospitalization. Many doctors don't think about this proactively, but they'll often make appropriate adjustments if the question is raised. Once you're in the hospital, don't hesitate to ask about your blood pressure readings and medications. You have the right to know what your vital signs are and what medications you're receiving. If you notice that your blood pressure is consistently low but you're still receiving blood pressure medications, ask the nurse to check with the doctor about whether the medications are still appropriate. Family members play a crucial role in hospital advocacy. If you have a loved one in the hospital, ask to see their vital signs chart and learn what their blood pressure readings have been. If you notice consistently low readings, or if your loved one seems more confused, dizzy, or weak than usual, bring these concerns to the attention of the nursing staff and ask them to contact the doctor. The concept of deprescribing is becoming more recognized in medical circles, but it's still not as common as it should be. Deprescribing is the process of carefully reducing or eliminating medications that are no longer beneficial or that may be causing harm. This is a specialized skill that requires careful consideration of each medication's benefits and risks in the context of the patient's current health status. If you suspect you might be over-medicated, ask your doctor about deprescribing. This isn't something you should attempt on your own, as stopping blood pressure medications abruptly can be dangerous. However, a knowledgeable doctor can help you gradually reduce medications while carefully monitoring your blood pressure and overall health. Lifestyle factors can also play a role in blood pressure management and may reduce the need for medications. Regular exercise, even just walking, can help maintain healthy blood pressure. Staying hydrated is important, especially for older adults who may not feel thirsty even when they're dehydrated. Managing stress through techniques like meditation, deep breathing, or gentle yoga can also help. Diet plays a significant role in blood pressure management. Reducing sodium intake can help some people maintain lower blood pressure with less medication. However, it's important to note that very low sodium diets can sometimes cause blood pressure to drop to low, especially in people who are already taking multiple medications. The key is finding the right balance for your individual situation. Sleep quality affects blood pressure, and some blood pressure medications can interfere with sleep. If you're having trouble sleeping, discuss this with your doctor, as it might be related to your medications. Poor sleep can actually raise blood pressure, creating a cycle where medications disrupt sleep. which raises blood pressure, which leads to more medications. The timing of medication administration can sometimes be adjusted to reduce side effects. Some people find that taking their blood pressure medications in the evening rather than the morning reduces daytime dizziness. Others do better splitting their doses throughout the day rather than taking everything at once. These adjustments should always be made in consultation with your healthcare provider. Building a relationship with a pharmacist can be valuable for medication management. Pharmacists often have more time than doctors to discuss medications and their effects. They can review your entire medication regimen for potential interactions and may notice patterns that others miss. Many pharmacists are also trained in medication therapy management and can work with your doctor to optimize your medication regimen. Remember that you are the expert on your own body. You know how you normally feel and what's normal for you. If you're feeling weak, dizzy, or just not right, and you're taking blood pressure medications, don't assume these symptoms are just part of aging or your medical condition. They could be signs that your medications need adjustment. The goal of blood pressure management should be to help you feel your best while protecting your long-term health. If your medications are making you feel worse rather than better, it's time to reassess the treatment plan. Your quality of life matters, and effective blood pressure management should enhance, not detract from, your daily life. Taking control of your blood pressure management isn't about second-guessing your doctor or refusing medical treatment. It's about being an informed, active participant in your own healthcare. By understanding how blood pressure medications work, monitoring your own response to treatment, and advocating for adjustments when necessary, you can help ensure that your blood pressure management supports your overall health and well-being rather than compromising it.